Okay, so we're going to start with basic neuro assessment because I feel like sometimes when we say like, oh, do neuro checks, does anybody know what that actually really entails? Like if somebody, yeah, I know. So if somebody came up and said like, oh, go do neuro checks on Mr. Jones, I'd be like, oh, what's your name, sir? And then like, you know what I mean? Like so I want to make sure that you guys know like what the full neuro assessment looks like. All right, so we're going to start with subjective. What does subjective mean?
What the patient tells you.
All right, so some of it's what the patient tells you. It's a good history, so we're going to go through just the basics. Are we ready?
Yes.
I'm going to give you a portion of the health history, and you guys are going to tell me why I want to know that.
Mm-hmm.
Okay, and how I apply it to the neuro assessment. Past health history, medications.
They can alter like your neural functions.
All right, so a lot of them can cause CNS depression, alter neural function. Why would I want to know previous diagnoses?
It can have an effect on your neuro.
Sure, like give me some examples.
A tumor.
Sure, if you've had a tumor in the past or you've had radiation on that tumor in the past, even if you don't have it now, right? We know that radiation on tumors or radiation on the brain causes problems lifelong. Surgeries.
If there's like a clot or something that's deep in the brain and like they have to go through all the healthy tissue to get that brain, they can like alter like a specific
Sure, so especially surgeries on the brain, but other surgeries can alter mental status as well. Yes?
Mm-hmm.
Or if you've had it, like let's say you've had a femur fracture. What do we know about femur fractures in neuro?
The blood clot can...
Is it blood?
No.
Nope. Femur fractures in neuro. What's your association? Big bone, little bone?
Big bone.
Big giant bone. Go on.
Poor cerebral perfusion.
No, it's like this one specific thing that typically happens from a femur fracture that causes major neurological issues.
Phantom pain?
No. Something that would travel up to the brain once you have a femur fracture.
Meningitis.
No.
Could a fragment of the bone travel?
Not bone, but you're getting much closer.
The joint?
Nope.
Calcium?
Where's your femur?
In your leg?
Oh. What, y'all have super skinny legs or something?
Oh,
the
fat.
fat.
Oh, we got some thick thighs in here. So fat embolism is very common after a femur fracture. So things like that is why you want to ask. Perinatal. Why do you want a perinatal history? Do you know what perinatal means?
Before birth?
It's prenatal.
Okay. So could that development have an effect on how your neuro?
Sure. So what did mom go through in pregnancy, right? Did she take medications during pregnancy, right? Was there any trauma, anything like that? And then you kind of want to know mom's history as well, right? Does she have any kids? Because honestly, I mean, those of you that have kids in here would know it messes up your brain for like the rest of your life. So I need to know, do you have mom brain or not? Okay. Growth and development. Was that normal? Was that abnormal? If it was abnormal, a lot of times, especially because the older people this generation right now, they didn't have the kind of assessment that we have, right? There was not developmental pediatricians. They just said like, oh, he's slow or something, right? And then it never got diagnosed. So that's something we want to know. All right, functional health pattern. I don't like that term, but basically what it means is what are you doing now that could contribute to your neurological status? Okay, and I'm not going to go over every single one of these with you, but it's things like, do you drink? Do you smoke? Do you have good nutrition? Have you been in the hospital? Do you wear helmets? Do you wear seatbelts? I want to know what is contributing right now. Do y'all see the difference?
Yes.
Okay. All right, objective. All right, so now you're going to go in and you're going to assess your patient. Okay, when I say do a mental status exam, there is a lot that goes along with that. Okay, so first thing, general appearance and behavior is probably one of the biggest things that you can assess from. You can tell a lot from somebody by sitting in front of them and looking at them. Just like I sat in front of you and I sensed something was off, right? Like you can tell a lot by how people converse, by if they've got the shakes or they have like maybe some tremors or, they seem very nervous and they can't calm down, or maybe they're very depressed. You can tell a lot. Does their appearance look disheveled? That's a big one. Because if you're going to the doctor, you're going to the hospital and they smell very bad or like their clothes are not clean, things like that. People that have depression or neurological issues that kind of thing just falls by the wayside, right? So you can tell a lot just by looking at someone. Their state of consciousness. So we do two things. One of them, I feel like everybody should do. The other one, I feel like nobody can do. Okay, so the first one, orientation to time, person, and place. How do you ask that?
Your name and date of birth.
All right, what's your name? What's your date of birth? What day is today? You can say who is the president, right? That's kind of controversial right now, but okay. And then this one, which I find so funny because most people can't even do it. Tell them to start with 100 and then subtract 7. Okay, everybody can do that one. That's 93. We got this. Okay, and then subtract 7, and then subtract 7, and then subtract 7. And most people are like, I would not know anyway. Okay. Just like I feel like, have y'all seen those videos where like people get pulled over for supposed drunk driving? And like, if I went out in heels on a night on the town and I did not drink at all, I still would walk like that. I cannot walk in heels anymore. After I had kids, it offset my balance and I look like a baby deer, so I can't go out anymore. All right, mood and affect. What does that mean?
Like their facial expressions is affect.
Okay, so affect, what is a flat affect?
Nothing.
No, like you can't tell.
Expression.
I am very happy. I am also very sad, right? And then their mood, how is that different?
It's how they're actually feeling.
Yes, or how they are presenting how they're feeling, right? Because I can't tell objectively how they're feeling, but I can tell how they're presenting that, right? Thought content. Okay, so I need to know if they have different illusions, hallucinations, or delusions. What are delusions? Oh, this is a psych thing y'all should know.
Fixed belief.
So delusions are things that you believe in, and hallucinations are either see or feel or hear or those kind of things. Yes?
Yes.
Okay. Intellectual capacity. Now, this is kind of controversial. Some people will include this in a mental status exam and some will not. Your intellectual capacity is totally different, though, from your mental status. Now, you can kind of tell when you're talking to someone what their intellectual capacity is. Do y'all know what that means?
Yeah, like their level or
Like level of education and things like that. So I want to be very clear and understand that may be something we're assessing, so I know how to teach this patient, but it's not something I'm assessing saying, oh, it seems like they only have like a 6th grade education, so there's something wrong with their mental status. That is not the case, right? So intellectual capacity is different from like your level of consciousness. Yeah? All right, and then we're going to assess 2 big, huge things, sensory and motor, right? So let's go over it very, very quickly. I'm going to give you one of the sensory things. You're going to tell me how you would test it. Light touch.
Like holding your hand.
Like lighter.
Cotton ball.
A cotton ball. So put a cotton ball, tell them to close their eyes, put it on an extremity and say, do you feel this or do you not feel this? Pain. Do not be mean.
like you like palpate something.
But yeah, it has to be a little bit painful, but not like super painful. You know how they have those little, it looks like almost like a needle, but bigger? Don't know what I'm talking about? No? Okay, picture in your mind a needle, but bigger. Okay. And then you kind of poke it at the bottom of their foot. So it elicits like a tiny bit of a pain response, but not to be like, you know? Because nurses used to do this in a very not so great way, and so they had to change how we assess pain. So when they were doing level of consciousness, they used to do, and I know y'all are going to be shocked by this, but it wasn't even that long when it happened. They would do a nipple pinch to see if the patient could become awake and alert. And then they would do it so hard that they would harm the patient. So please don't do that anymore, okay? We don't do that. Now they'll sometimes do like a little sternal rub, but it shouldn't be like so hard to where you would actually like cause damage to the patient, Obvi. All right, temperature. How do you assess temperature? This is very...
Thermometer.
Okay, let me... Everybody at one time goes, it's a thermometer. You're assessing if the patient can feel temperature. So...
Cold water or something.
Or like an ice cube, right? Or you could put that on and say, hey, what does this feel like, right? Okay. Vibration. Don't get weird about this. Do not get weird.
Like a vibrating phone.
No.
Is it like this, the sensory fork? Or
Yeah, it's a tuning fork. You know, the ones that you use?
I'm sorry.
She's all, be still while I had to have someone call me so I can vibrate this. Okay. Position sense. What does that mean?
It's like finger to nose or
No, it's like
No.
their position, like how they can
Oh.
feel where their body's position is.
Would you like move them and ask them? Like,
Or
what
ask them to
position
sit
they're in?
up, or ask
Do you know what the Romberg test is?
Yes.
yeah.
Okay, so you could do a Romberg so they could see where they are in position. Oh, yeah, you remember that? Yeah, we bringing back health assessment from way back when. All right, cortical sensory. All right, what about graphesthesia? What's graphesthesia?
Ability to recognize like a number drawn on your hand.
Yes, very good. So we'll draw a number on their hand and see if they're able to recognize that. Stereognosis.
Being able to recognize an item being put in your hand, so like a key.
What, did you prepare for this or something?
No.
She's like, no, I just studied health assessment like really good. Okay, so say again what it is.
It's when you like you have to recognize what is put in the palm of your hand, so you can put like a ball or like a key, and they have to like feel it and close their eyes
Like a
and
game.
yeah, kind of
Yeah, like you do this with kids.
Yeah.
You know, and y'all probably did this at school when you were younger. Like put your hand in a bag and hold it and see like if you can feel whatever it is, you know. And then reflexes, y'all know how to test DTRs, I would assume. Well, I'm going to ask you just to make sure, because when I've asked y'all things today and y'all said yes, I'm not quite sure that you know.
That thingy?
Yeah, the thingy.
Reflex
What's
hammer.
the thingy? A reflex hammer. Okay, and then we're going to assess reflexes, yes?
Yes.
Okay, what is normal reflexes? What number?
+2.
Okay, thank you. All right, now we're going to assess motor. We're going to assess their gait, which is
Walking.
how they walk. Tandem walk.
arm and leg opposite.
And heel toe. Yes?
Yeah.
Okay. What's the Romberg test?
The swing.
Yeah.
What's the swing thing?
The
So you're going to have them stand up, arms go out straight. Good job. And then you have the patient close their eyes. Now, what's your most important nursing intervention during a Romberg test?
Catch them if they fall.
Stand behind the patient, right? So that way, wherever you're going to be standing like this. Okay, because yeah. All right, symmetrical muscle bulk. That sounds weird. But it is exactly what it says. So if that helps you at all. Symmetrical muscle bulk.
So like even muscles.
Yes, our muscles the same. Do we have atrophy on one side?
Okay.
Or hypertrophy? Okay. Tone, muscle tone.
Are they toned or not?
Oh my God, I do not ever want somebody to do a neuro assessment and be like, girl, you are not toned at all. You need to do some sit-ups. But it is looking at like the actual tone of the muscle, right? You can still see if they have atrophy. And the muscle strength, how do you assess that?
Have them push.
You can have them squeeze your fingers or squeeze your hands, right? And see if it's symmetrical on both sides. Finger to nose. Heel to shin. That one's kind of hard to do too. Do you know what I'm talking about? Heel to shin.
You have to shin.
Yeah. We're like, oh
What
God.
if they have a clot? Boom.
A what? No, not like that. Not like that. Not like that. You have them stand. I don't even think you can see this on the video. You have them stand up and do this without holding onto something. Yeah.
Something else.
Okay, yeah, that's why I show you things. Okay, that got weird. All right. Do we understand the motor? Okay, now we're going to do, you'll have to know your cranial nerves. So I gave you a cheat sheet. You need to know the cranial nerve, what number it is, how to assess it. Okay?
Okay.
Are we clear on that? All right, and then we're going to quickly go over Glasgow Coma Scale. Okay? Do not look at your paper though. Okay, what's a normal Glasgow Coma Scale? 15. Minimum score? 3. Okay, good job, everyone. Okay, max score for Glasgow Coma Scale? 15. Minimal score? 3. What 3 things does it test?
Their pupils.
No.
Oh, motor.
Okay, motor response?
Yeah, motor
Okay.
response.
Alertness.
No.
Cognition.
None of those things are happening in the Glasgow Coma Scale that you should have learned in first semester.
Okay, well we have.
That's motor response. 1 out of 3. Okay, so get out of your brains. If y'all walked into this room right now and I went, "Muh," and I fell out, what would you go and do? Oh, well,
their
crap,
response.
nothing? I guess I'm just going to be dead, huh?
Their response.
Well, okay, so motor response, what else? What would you do? What's the first thing you would do?
Wake them up.
Okay, yeah, you would go and be like, Amber, are you okay? Are you okay? Right? That's a verbal response, right? So I'll either be like, or be like, yes, I'm fine, leave me alone. Or I'll be like, damn, y'all took a really long time to get here, right? Okay, so that's the verbal response. Is the patient able to verbalize back to me when I talk to them? Okay, and the last one is eye-opening response, right? So when I walk into the room and they hear me, do they just, spontaneously open their eyes? Or if I have to call their name multiple times, other Amber, other Amber, other Amber, and then you're like, okay, that's a little bit more, right? Or if they're really not doing that, right? So there are different scores for each category. So I have the handout for you here. You guys need to know how to Glasgow Coma Scale score someone. What's the rule for like, this patient is not doing good?
The higher the number.
No, the higher the number, the better they're doing,
Sorry,
right?
lower the number.
What'd you say?
8.
Less than 8, what do we do? Intubate. Less than 8?
Intubate.
Intubate. It's a rhyme. It's Dr. Seuss week at ME school, so I'm probably going to rhyme a lot today, yeah. All right, so less than 8 intubate, because at that point, like their neuro status is so not so great that they're probably not going to be able to maintain their own respiratory status. Are we clear on that?
Yes.
Okay. Anything less than 15, though, is an altered mental status, right?
Yes.
And we need to watch, and that's why we're doing GCS very often to see if there is a neurological change. Do we understand?
Yes.
Questions on basic neuro exam?
I don't have that paper.
Would you like it?
Yeah.
Okay.
I don't have it either.